Welcome everybody to today's this month's meeting of the CHC board meeting, and not seeing anybody that isn't the usual suspect, so we will start with well, introductions as you're signing in. Public comment. Do we have anybody who wishes to make public comment? Donna Mills, you may want to make public comment at this point.
I've got some public comment to make. I just wanted to let everyone know, if they hadn't seen the press release, the behavioral health investment that we spoke about a couple of months ago was actually finished being distributed on Tuesday of this week. It was a little north of $4.1 million. And it went to support behavioral health needs around student suicide, veterans, older adults, and uninsured and underinsured folks in Central Oregon. We're really excited to be partnered with a number of very worthy organizations in our region, and are looking forward to the work they're going to be doing. So thank you very much. I want to thank my team that worked really hard to get those funds out the door within a very short period of time, and still in a very rigorous and appropriate manner.
Okay, and thank you, Donna Mills, for that hard work in a short period of time. It was great. And so the next agenda item is approval of the agenda and the consent agenda, which is the minutes, the ED evaluation project, and the ED job description. So
Rick, this is Linda. I'd like to pull the ED position description and the process, just as a regular process of when we come up with the policy. It goes by governance committee before it goes to the board as a process of review. And this went straight from those of us who were working on the document to the board.
Perfect. Okay, fine. So with that, Linda, I
move adoption of the consent agenda, withdrawing the ED position description and ED review.
And I'm also hearing a commitment that you will review the ED evaluation process and job description and governance committee over the next month. Is that right? I heard that, didn't he?
Yes, that too.
Yes, great. So we have a modified acceptance of the agenda and acceptance of the board minutes as consent agenda. Can I hear a motion?
I think that was, but I'll second.
Okay, great. I can't make a motion. Oh, Linda made a motion. Great, perfect, thank you. And all in favor?
Aye.
Got a lot of ayes. Any opposed? No. Good. So, Dr. Sharma, patient story.
All right, thanks, you guys. A year ago, the behavioral health consultant at La Pine Community Health Center reached out to all the providers, asking if there was anyone who'd be willing to provide gender-affirming treatment. This was not something that had been offered at La Pine before. I offered to help, and subsequently a few providers asked if they could follow along with me to learn so that they could provide some service also. So this led me to meet patient X. X is a 19-year-old adult who came to me a year ago to discuss wanting to undergo gender treatment to help achieve mind-body congruency. She had been living in her misgendered state for a previous 18 years in La Pine and was feeling very isolated. She has severe anxiety and has had frequent suicidal ideations. She dropped out of school due to this anxiety and depression partway through high school. She has extremely supportive parents and siblings and has been connected with Deschutes County Behavioral Health. But outside of that, she really has no other contact in the community. So in our early days, she struggled with making much, if any, eye contact. She had long hair that covered most of her face, and she spoke very cautiously and guarded, and was extremely guarded. She was, however, very clear that she was ready to start treatment. She started treatment a year ago. She uses the patient portal frequently to communicate with me, and she follows through on getting her labs and keeping her appointments with me as instructed. Her counselor and I communicate easily across our EMRs because both of us, because Deschutes County Behavioral Health and Lapine Community Health Center are both on OCHIN Epic EMR, which really makes for the ease of communication incredible. With the pandemic, then there was another opportunity for us to have the video visits. So she's decided to video call with me while visiting her brother in Ashland 6 months into her treatment. When her video camera came on, she had her hair pulled back, had on makeup, she was wearing a dress, smiling big, and she looked radiant. She told me that she had been out walking, and though she was scared, she felt good. A few months after patient X started her treatment, a second patient, patient Y, came to me wanting me to take over her gender affirming treatment. Patient Y too was 18 years of age, but had started treatment a few years prior through OHSU and was excited to hear that she could actually get treated locally because just driving out to OHSU was a barrier. She came to me accompanied by her mom. While she was not as anxious as patient X, she too struggled not only with anxiety, but also social isolation. She was surprised to hear that there was another transgender person in her community undergoing treatment. I asked if she'd be interested in getting connected with this other person in the community. Her mother, of course, was ecstatic and wanted her daughter to do so, but the daughter was hesitant and needed more time to think about it. I then also spoke with patient X and let her know about the existence of patient Y in our community, and if and when both would be ready, I'd connect them with each other for support. Patient X recently told me that she was ready for me to give her contact info to patient Y. I'm getting ready to meet with patient Y shortly to see if she's ready to get connected. In the meantime, another provider at Lapine has now also started treating a transgender male, and with our BHC, the three of us are discussing setting up a transgender support group in Lapine. This story is meant to just kind of highlight the challenges for transgendered people. We know that their challenges are many, and they are just so much more amplified in rural settings. So I feel grateful to have the privilege to work with such a vulnerable and critical subpopulation, and my amazing colleagues at Lapine Community Health Center who are also very passionate and driven to bring about this health equity.
Good story. Excellent. Then Kelsey, you had a little announcement.
Thank you. I'm looking up in the corner and maybe it'll pop back up later on. It's been a little off and on today. We now have closed captioning available for our meetings. Like I said, today it's on and off. So if you see it pop up in the top right corner next to where it says recording, it'll say live on rev.com. That does not mean we're broadcasting this meeting somewhere. This is a public meeting and the recordings do end up on YouTube later, for those of you who did not know that. But we are using an automated service to provide closed captioning. When it comes back on, you'll see down at your menu bar the closed caption symbol. You can click on that and turn them on. They're about 90% accurate or so, and you can adjust the size of them and drag them around out of the way if they're blocking something. But that's something that we've done to make our meetings more accessible. So we hope you enjoy that feature. Thanks, Rick.
Thank you. And we wanted to insert, as we start talking about governance, Linda, this is your opportunity before we have Leslie go. Linda? Linda, are you frozen? Are you able to talk, Linda?
I'm not able to hear anyone. I got a message that my network bandwidth was extremely low. Okay, so if you guys can hear me, I will charge ahead and hopefully my sound will come back. Is that okay, Rick? Great, okay. As the board will remember, last month we brought the policy manual forward for adoption, and the board asked Megan, Dan, Donna, and I to look again at what we call the governance structure and how we name that in the document itself, and then come back through the governance committee. The proposal that you see before you is as a result of the conversations with all of those groups. Governance took an email vote this week, and I heard back from all but one who were very supportive of this. And Dan and Megan and I also are supportive. And thanks to Dan for all the research and discussion and the learning that I've had about this. And so I'll share a little bit of that. The text of the change removes the naming of our process, but says it is consistent with the best practices of nonprofit governance. And one of the things we discovered is that the Carver people have trademarked the name policy governance. So if we use policy governance, then we are potentially infringing on trademark. And the second thing we talked about was, well, okay, maybe we could define how we're different from policy governance, which would require a long, exhaustive review and list. And we felt that simply removing policy governance and replacing it with using best practices of nonprofit governance really met the mark of what we were achieving or hoping to achieve. So with that, we're asking for the board's approval of the document, the entire policy book with this language changed.
So we have a request. Can discussion before I ask for motion? Okay, we beat this to death. So can I have a motion?
So moved.
Second.
Okay, great. All in favor, say aye or indicate thumbs up.
Aye.
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 Probably more important in these Zoom meetings. Anyone opposed? Abstentions? Okay, I'm going to take that as a unanimous. We'll take
Thank you. Yay.
Yeah, good. Thank you. Leslie. You're
Hi.
on, or-
Thanks.
Go ahead.
Yeah, thanks for sharing this. Michaela, it looks like. Thank you. All right, so you all, I think, are familiar with our CCO performance metrics that this group endorsed. I think it was the January meeting for 2021. You've seen these previously in a quadrant, 4-quadrant style. I tried to make it more visually appealing, and when I say a colleague of mine did this. Formatting is not my strong suit. I'm much more interested in the content of a document, so I was very pleased. Hopefully this is more visually appealing than what I have presented in previous quarters. So I am presenting the Q1 update, excuse me, for this group, which happens every quarter, 2 months after the end of each quarter at this meeting. So you've seen this information on the left is really what was represented in the quadrants. You'll see, like, the first one is quality and member experience, just to orient you. And so you've seen and endorsed the left column here, the green, yellow, red status. You'll see, excuse me, quarter to quarter. I just hid those rows on the Excel sheet. So for Q2 when I come back in 3 months to present that information, you'll see Q1 next to Q2, so we can see any trends through the year, and we'll just continue to add that information as the year goes by. And then I just have some notes here. I'm not going to read all of this to you, but I do have a couple that I wanted to touch on. You don't have to scroll this document right now. Hopefully you read it, but or at least saw it. You'll see that everything is on target with the exception of the quality and sensitive measures, which are in yellow. There are some notes there about oral health being some of the metrics of concern there, and then some of the mitigation or action plans that are occurring now and have been occurring for quite some time. So that's really the only kind of metric that is, officially not on target. Of course, it's early in the year. That is information again through the end of March, and we have some mitigation plans for future weeks, months to come. If you want to scroll down to in the middle of the document, so under CCO 2.0 requirements, there's the SHARE initiative funding stream. So this SHARE stands for Supporting Health for All Through Reinvestment. This is a new funding stream through CCO 2.0 that basically says if there is any net income at the end of each year of the 5-year CCO contract, a portion of that needs to be spent on this SHARE initiative. And we had some discussions with the state about, well, we do this as far as in our community health council model through shared savings. This is on top of that. I think more discussions will ensue, but for the purposes of this group, it will help you to know that we have just landed on a figure for this for 2020 net income, and a portion of the SHARE funding will be, I think it's just a little over $57,000. One of the requirements for this funding stream is that the Community Advisory Council plays a role in directing these funds. And so our team is working with the COHC Health Council staff to determine what that role might look like for the CAC. We're presenting this information next week. We hope to learn more. And then we have a spending plan that's currently due at the end of September that will have to outline kind of the intentions for spending those dollars from 2020 in the year 2021. So that's a requirement again for the full 5-year contract for CCO 2.0. So that's just probably newer to this group. Wanted to touch on that. The next one right under there, under required plans, is I just wanted to point out the health equity plan. You've seen presentations about some of the elements in our health equity plan from Miguel and Kate previously at this group. I just wanted to point out, and to a little horn here, not mine, many other people in the organization, but that we did receive some scoring from the OHA, and our CCO scored among the highest in the state, so 59 out of 62. We have a ton of work on this health equity plan occurring internally and externally. And so just wanted to point out that, we were pleased that we scored high, of course, but there, the real work is yet to be done. So much more to come there, and we'll be coming back to this group many times throughout the next few years to give you an update. If you want to scroll down, the other one I just wanted to touch on, I think is towards the end under operations. Oh yes, so there's a metric that says launch new member access to care survey. This is kind of a newer initiative. Just wanted to remind or let you know, I think some folks heard this in the CAC, but that we launched a member access survey in December of 2020, and we're working with a vendor to do that. The response rate was not great. This is kind of expected, but lower than we expected. However, we're working to have some potentially other avenues to launch that survey for more of a response rate, but I'll have that Q1 report any day now. So just wanted to keep you posted. I'm happy to entertain any questions on any of these metrics or on please give feedback on the document itself as well.
Okay, this is the board's opportunity to oversee CCO operations. So any questions? Okay, good job. Thank you, Leslie. That was very helpful. And then you're also have the next item, the Senate Bill 889.
I am. Thank you again, Michaela. Okay, so this is a bit of a long story, and I already want to tell you, I'm sorry for the amount of detail. We tried really hard to cut these slides down, but we're struggling with, but it's so important. It's such good information, but it's way too many words on some of the slides. So apologies in advance, and this is part of hopefully when you get the packet ahead of time that you can tease out some of these. and hadn't have some questions at the ready. So some apologies. It's not the way I like to start a presentation, but some apologies in up front. There's just some of this can get really weedy, and I'm going to try hard not to do that. But also, this is just really good information for you all to have, and some details that I think would be useful as a reference for you in the future as well. So really, sorry, you can go to the next slide. The goals here are just to understand what some of the key elements of this Senate Bill 889 from 2019 is and were, and what this voluntary value-based payment or VBP compact is, and then wanting to talk to you about some of the similarities and differences between what that Senate bill says and what this voluntary compact is doing, and those of CCO 2.0 and some of those requirements around value-based payments. So the next slide. Really, this is just an overview. I'm pretty sure all of you know this, but the intent of value-based payments is really around looking at quality and reducing total cost of care, emphasizing value over volume, and incentivizing innovations, basically, really looking at positive outcomes, wanting to offer flexibility to providers. And this is in an effort really to stabilize the health system in the state of Oregon. There are many other pieces here, but that's just kind of like your quick and dirty overview or refresher, if you will. So again, this Senate bill passed in 2019. What it was really intended to do was encourage, or I guess this word is mandate, but alignment between public and private markets, really. So this is, they have now changed the Senate bill is moot now, of course, but this is how it started. It has since, there was an implementation committee that was formed, and it has since been called now this voluntary compact that includes payers, providers, and purchasers, and is known as the Sustainable Healthcare Cost Growth Target Committee, not a short name at all. Just wanting to let you know that part of the implementation committee, regionally, we had Jen Wielander that was on that committee. She is no longer, of course, on that. Representing from a regional perspective, we do have our CEO at Pacific Source that is still part of this work and is really involved. You can see some of the opportunities that committee is interested in looking at, and what they've really been directed to from the legislature. And again, this is really, many of the principles are very much aligned with the CCO 2.0 value-based payment roadmap requirements, which I am certainly more intimately involved with. You can go to the next slide. Some of the specifics here, the cost of growth target is set at 3.4% for the, well, it's not exactly the CCO contract 5-year period of time, but close. And then decreasing that cost of growth target in future years. So that's really what the Senate bill mandated. There's a focus, of course, on quality and efficiencies. You can see some, they're really focusing on alignment between commercial Medicare and Medicaid products. They're focusing on alignment between payers. And so this voluntary compact, it's pretty well, you can see a list of folks you can see a list of participants. It's pretty long, I have to say. There's been a pretty good uptake of this and this voluntary compact kind of moving forward over the last 2 years. And then the committee, they're promoting and making sure that they're monitoring for any unintended consequences. This also goes for value-based payment models under the CCO 2.0 requirement as well. We're looking at risk adjustment, we're looking at health equity, we're looking at parity. We're making sure that we don't run afoul in any of those areas. Excuse me. You can go to the next slide. So some of the directives for this implementation committee were really around accountability and enforcement. You can see some of these listed here. They're really, they're really charged with making sure that they're complying with the reporting requirements, that they have a performance improvement action plan and any escalation plans needed. They're, and then of course, enforcing that healthcare cost growth benchmark. There are a lot of reporting requirements, and I won't get into those. Again, I'm trying not to be too weedy, although I know this is already occurring. But let's move to the next slide where perhaps it might be more interesting to learn how this Senate bill and this voluntary compact interacts or how it compares with the CCO value-based payment requirements. The next slide, again, not a great slide to share in a forum. You can go to the next slide, Michaela. It's a small, hopefully you can see these dotted lines, but the point was really to show you that on the left, these are the qualifying categories under the CCO contract as far as the value-based payment roadmap goes, and then what the qualifying categories under that Senate bill are. You can see it kind of pushes the envelope on the right there. So the Senate bill is really looking at these categories as 3 and 4, which they feel is potentially more value-based payment arrangements. This is the land category framework that the state uses and is used in many other parts of the nation as well. I think you can see this okay, but category 1, just to give you an example, is just fee for service, right? So this is kind of older model, if you will, not linked to inequality or value. Category 2 kind of pushes it a little bit more to link it to some sort of linkage to quality and value, which is, we've noted here, our patient-centered primary care value-based payment requirement fits in that category 2. Category 3 really pushes alternative payment methods that outside of fee for service that are again looking more at shared savings, upside and downside risk, for example. And then category 4 is really looking at that population health-based payment models. So while the CCO contract, and there's some stepwise, I'll get to this in a future slide, but there are some stepwise requirements for both the CCO contract and for the Senate bill work, to kind of ramp up to this, and you'll see that in a future slide. But the CCO contract kind of started from very much of a let's just get this started right in 2020 and 2021. Some of these are waived for COVID under the CCO contract, but some of the Senate bill and the voluntary compact work that's being done is really kind of pushing that a little bit faster and harder, if you will. There is some alignment, of course, but you'll see another comparison slide. The next slide, Michaela, is looking really at the requirements. Sorry, not that one. That was my colleague's comment to me. So the next slide is really looking at some comparison of some key elements between, again, CCO 2.0 requirements and the value-based payment space, and then also this voluntary compact. Of course, CCO 2.0 is really just looking at our Medicaid population, where this voluntary compact is looking at all payers, all lines of business, if you will. There are many more, as you can see just from the illustration of this graph or these tables, is that there are many more requirements on the CCO 2.0 contract. I think there are many theories as to why the voluntary compact implementation work group is really just, a group of folks that are saying, yes, of course, we want to move towards this, but they're not going to put any hard and fast requirements. And then also, of course, it's always helpful and easier to make requirements when there's payment attached, right? So that's part of why the CCO contract has these, as you can see, little more stringent requirements there, and just some more guidance there, guardrails, if you will. I'm just wanting to, I probably should have said this up front, but there's not a lot of concern on the CCO 2.0 contract piece. We feel really confident in Central Oregon that we're meeting all of these requirements, and that we have for many, many years. We think that the state kind of took a page out of the Central Oregon book and said, this seems to be going really well in Central Oregon, and maybe we should mandate it for other parts of the state as well, and with the CCO 2.0 contract. I think you can move to the next slide. There's one more kind of comparison chart here around the minimum thresholds. So this is just, again, 2.0 requirements on the left and voluntary compact on the right. I'd mentioned already, as far as the categorization goes, the CCO contract kind of ramps up and starts a little lower and then ramps up to higher land categories in that framework year over year. And then the voluntary compact is a little bit more fast and furious. So again, alignment for sure, specifically with some of the percentages, but certainly pushing it a little bit harder on that voluntary compact side. again, you may have seen this in the Q1 metrics around the VBP requirements for this roadmap, where the 70% target by 2020, 70% of our arrangements must be in this is saying 2C or higher land category by the end of our 5-year contract with the OHA. Right now, currently in 2021, we're sitting at, I think it said 62 or 63%. So we're feeling pretty confident, like I mentioned. Again, that's for Medicaid. The next slide will tell you where this Central Oregon is looking. Of course, now I said 63 and this says 52. These are two different data sources. Oh, sorry. Sorry. The 63% is 2C and higher. Again, apologies for the weeds, but this is looking again at this voluntary compact, which is really just looking at the category 3 and up. So categorization of contracts that are considered 3B or higher, which I will just tell you that all of our Medicaid contracts, with the exception of one really, is considered 3B in Central Oregon. So again, I need to recheck my math there, or the data sources, excuse me. But really the story here is we have a lot of work to do in the Medicare and commercial space to get to where this voluntary compact is mandating. So I have to say, though, these numbers in Central Oregon look much better than our other regions, which is probably a good story for this region. I think we certainly have some plans. Our VP of Provider Network and our Director of Provider Network are working really hard with, excuse me, provider organizations specific to those working in Medicare and commercial to get us, really where we said we were going to be in this voluntary compact. And this is certainly a big part of our organization's strategic plan to get us to a more value-based payment space for all lines of our business. So I'll stop there, excuse my scratchy voice. And the next slide is just a question slide. So I'm happy to entertain any questions or any comments from anyone.
Leslie, this is Linda Johnson. In one of the earlier slides, you referenced that a part of the objective was to reduce over availability of certain providers and match the number of providers to the region. Are there any provider specialties or groups or classes in Central Oregon that are at an oversupply right now?
I don't know that off the top of my head. I actually wonder if Divya might not know more, at least in the specialty space, or Dan, I suppose.
So the specific question is in the specialty space, there's greater, I didn't catch the part of.
Is there an oversupply of providers for a specific type of service?
It's hard to generalize it to all specialties. I think from an access standpoint, we definitely have in this area some specialties that we have really good access because there's a lot of them. Other specialties, it's just maybe one group. So it just depends on the type of the specialties. In the pediatric space, definitely, I would say those are much more highly specialized. So a lot of pediatrics care does happen to go outside of our area because we don't have a lot of those subspecialists in our region. Yeah, but and then, I think the good news is I think most subspecialties we do have in our area. It's just a matter of whether we have multiple groups of them or not.
I know in our prior discussions, we've talked about needing more primary care physicians, particularly in the rural area, and behavioral health. We've talked about a shortage of those. So I'm more familiar with the shortages, and it just made me question, are there any that we have more than we need?
Leslie, this is Eric. A question along these lines. is the sense to let the market take care of oversupply in a particular area, or let the pressures of the compact do that?
Yeah, I mean, I'm thinking it's probably a braiding of both. You know, certainly the voluntary compact is charged with pushing some of this. I imagine some of it will happen organically. Excuse me, but yes, I do think that there will be some pressure, I suppose, from this work.
Thank you.
Thank you.
Yeah, Eric, this is Dan. I think the main thing that the compact does is commit organizations to advancing value-based care and value-based contracting as one of the key, elements to cost reduction and living within the cost target outcomes, the growth target outcomes.
Mm-hmm.
I think that there's probably an indirect line, but a line between, there's an assumption that says, well, if organizations are working together toward value-based care, then maybe that organically right sizes getting the right number of specialty providers in a region based on per thousand or population statistics, because the supply side demand can generate the opposite, right? I mean, when it's fee for service and when it's sort of demand is supply driven, then the opposite can occur. So I don't know of a direct line there in that compact, other than the suggestion that outcome is probably a causal outcome from working toward value-based care and contracting.
Right.
Yeah, kind of an interesting link.
Thank you.
Leslie, this is Donna. I also wonder, in the compact itself, and you may or may not be aware of this, are they having conversations on how the non-traditional healthcare provider can also work alongside? So the CBO actually participating in that compact to keep those costs down as well as another lever.
I don't necessarily think that's out of scope of what they're working on, but I think anything goes, right, to ensure that the cost growth target is met, to ensure that these metrics are met. So I haven't seen anything explicitly called out that says, yes, we need to go here in order to meet these targets, but it's not off the table by any means.
Thank you.
Leslie, this is Megan. I'm curious, and what I'm getting from this is that we're accountable to the compact as far as where we land with our value-based pay versus what is in the CCO contract now. Is that accurate?
Yeah, I mean, we're beholden to both.
Okay.
Which is, a blessing and a curse, probably. I mean, well-intended, right intentions, right? This is obvious work that needs to be done, but as far as reporting goes, one is tied to revenue, right, and the other is tied to a Senate bill with some mandates. I mean, we're going to do both. I think it will be in some ways harder, to push the voluntary compact rock. But we're doing it, and we have intentions to do so, and we're already having these conversations, and our organization is well aligned with this compact and the work that they're doing, and we've already started these conversations. This was really just to let you know, in case we haven't approached you yet. We probably will be soon.
And Leslie, do you think there's a role for the Health Council in being aware or monitoring where we are with the different requirements of the compact over time? And I know some of the data and the reporting happens after you're in, like 6 months later, to see how the different payers and providers performed. But is there a helpful role the Health Council could play with maybe even proxy data as we're kind of moving through the year over year?
It's a great question. I mean, I'm happy to report the data as I receive it, or as we receive it, biannually or I'm not sure if quarterly that we'll have it. But I'm more than happy to do that. As far as the role of the Health Council, I hadn't really thought that through. This was more of a heads up for you all. But I'm happy to talk to Donna more. I'm happy to get feedback from anyone on, any board member on what they feel like their role might be here.
So Leslie, I think one of my questions in this is purely coming out of complete ignorance, so it's not a leading question at all, is do you see, is there a way of potentiating what you've done on the Medicaid side to help with what you're doing on the Medicare and commercial side? What would that alignment look like? And that's a poorly formulated question, but that's because it's coming out of ignorance.
Actually, I think it's a great question and something that we actively discuss at Pacific Source regularly. So this is that's also kind of part of our general organizational strategy, is really taking the learnings and what's going well, and certainly pitfalls of what we've experienced in the CCO Medicaid space, and aligning that to our other lines of business, and really leveraging the great work that has been done through some of our Medicaid contracting in particular, and some of that lessons learned, and some of the great things that we think are occurring through that, and trying to translate that to other lines of business as well. I think it's going okay. It's a bit of a whole new world, right, for other payers or other organizations, other lines of business that haven't really broached that. I think in Central Oregon, of course, we're poised because of the shared risk arrangement that's been going on for a decade, and how that's evolved, and those partnership conversations that have, I think, gone really well. And we've had some, respectful, challenging barriers. And I think that we're trying to take those learnings into other lines of business whenever possible.
Hey, Leslie, I would just add on the concept of kind of sharing, where is Pacific Source across various lines of business on these things. Ultimately, there'll be some public reporting, obviously, as it relates to the compact and organizations making progress on the cost growth targets. As Leslie said, we have begun to and will continue to have some kind of leading indicator internal reporting. And if there's interest from the council, I don't see any reason why we would view that as proprietary, just sharing that with this body as colleagues and interested stakeholders. So if there remains an interest in that, keep us posted. We'd be happy to share that.
Yes, I think I'm seeing some nodding, and I would certainly, try to make sure that the Health Council on the original mission is one of speaking to health of the community more broadly, and not simply the CCO contract. And then two, also just in speaking to the CCO governance, understanding the broader healthcare environment that you guys are experiencing is really critical to ensure that we're placing the CCO in the right place. So whatever you're able to share with us, I think is helpful. Obviously, there's details you don't want to get into, but giving us context about what's happening in the region and across the state in your other regions is super helpful, I think.
Yeah, absolutely. And that's a two-way street in terms of, recognizing that the CCO is doing business in this broader ecosystem, right? Bigger than just Medicaid. So too with many of you around the room, providers, education organizations, et cetera. So public health. So that conversation, I think, is useful potentially on both of those fronts. So we certainly wouldn't come in and say, here's what we're struggling with Summit Medical Group on advancing value-based payment in some area that Justin doesn't want to. Actually, Justin's pretty gung-ho about this stuff, but we can share generalities that would be relevant.
Okay.
Yeah.
Other questions? Okay, good. Obviously, you've generated some interest, Leslie, so good work.
Thanks for your time.
Long-term systematic change. So, Dr. Sharma, do you want to speak to the CUSC meeting? It was the 5-point
Sure.
plan.
Yeah, we're still fleshing that out, the 5-point plan. But I think at this point, there was a small group of us who met at CUSC. And what we're trying to figure out is really developing kind of a focused area. You know, I think there's the question really is about two fundamentally different approaches. One is, do we come at small things that over time, over years, small changes, you know, a little change here, a little change there, maybe a little efficiency here and there, would result in decreasing waste and increasing savings. But from a year to year, you wouldn't be able to kind of say it was this that caused that saving. And certainly not on like any quarterly type of a tracking system. So that's kind of one way, you know, that potentially, I guess, you know, we could be going or working on things. The other is there one or two kind of big things? And what are those? And that fundamentally shifts the way we practice care in this community or deliver care in this community. And can we find that one or two things, get really good at it, and we expect a much bigger impact of that? So I think those are the two discussions we're having. And I'm not going to say who's in which camp right now. And so that's kind of where we are. I don't know, Rick, do you have anything back to that?
Yeah, and that's, I wanted you to cover the medical side, and it was actually a fairly organized proposal and plan from Pacific Source, which I really appreciated. And then then there will be a separate initiative that has already got started around behavioral health. And so Mike Franz is leading that and has given us, Janice Garceau and I, a fairly extensive slide deck of their analysis of behavioral health spend over since 2016. So we will be discussing that next week. So those are the initiatives. So basically, I think the idea strategically is having a subcommittee, the CUSP, lead that initiative. Sort of was not the right way of going about it. And it was really to partner with Pacific Source and see how we can have a dialogue and get some focus, and then potentiate the provider system to help with those cost-cutting initiatives. Is that a fair statement, Leslie?
Sounds fair to me.
Okay.
I mean, I agree with Divya. We still haven't landed, right, anywhere.
Right.
I mean, you know what I mean. We've had great conversations. thanks for the kudos on the plan, but we didn't endorse that plan.
Right. Right. But you know, as a psychotherapist, having a good discussion is all I needed. So that's all good. Yeah, no, we're getting there. I think there's some stuff happening. We're not in an action stage yet. Okay. Any questions around that? Okay. Don Mills, SB 741.
Process. So this week, I was able to testify in front of the House Committee on Healthcare regarding Senate Bill 741, and I wanted to thank you all that submitted written testimony yet again on our behalf. And I wanted to give a shout out to Patty for actually being on the line and speaking. And actually Representative Salinas actually asked me a question, which was awesome because then I knew they were actually listening to what we were saying. Super fun. So now we'll be on the lookout for the work session within the House Committee and their vote. I did get to hear that the Senate, when they recommended approval for the bill, actually had no nays. So we got all yays on that side, which was pretty cool. So again, thanks to everybody for their support, and hopefully we'll know soon. The other thing I wanted to bring to your attention was just a little bit of an overview around the retreat. I know it's early and we aren't retreating until September, but just so the things that we know that we will be virtual. We will not be in person again in September. And really the approach that we are taking with the assistance of our governance committee is actually a two-pronged approach around our board eval. We're going to actually enlist our CAC in a survey and the board in a survey. Some of the questions there will be overlapping and some of them will be separate and unto those bodies themselves. We'll accomplish that over June and July, and then we will bring, me and the mouse in my pocket, will bring to the board in August an overview of the results from those surveys and give you a preview of what we will actually do in our retreat together. There'll be a couple of different presentations on the retreat day, one specific to CAC, one specific to the board. And then we'll be bringing you both together to work on some items that are elevated and bubble up from the survey. So we're really looking forward to it. I do want to thank the governance committee for allowing us to take this approach for benchmarking for the board self-eval. Of course, we've done a self-eval once before. A lot of you weren't here then. And we will be resurrecting and looking at that and letting it help inform us as we put the new pieces together. We are working with the leadership group, which is some facilitators that I've worked with a really long time, pretty amazing folks. And so more to come on that. So I just wanted to kind of give you a preview of what to be looking for.
Okay. Any questions? Okay, Gwen Jones, you're next.
Hi there, Michaela's gonna project. For the next 20 minutes or so, we're gonna talk a little bit about RealD data and the demographics of the health councils, specifically you all, the board. If you do wanna put it in projection mode, Michaela, as you're able, and then go ahead and move on to slide 2. There you go. Go ahead, yep. So we are gonna just get equal set with some definitions around some concepts that are important to what we're talking about with regards to RealD. We're gonna define it and understand what it is, talk about why it's important in general and why it's important to the Health Council and the Health Council board. Then we're gonna actually take some time for y'all to complete a RealD survey. to the level that you're comfortable and willing to. And then we'll talk about what's going to happen next with that data. So next slide, starting with some definitions, keep moving forward. When we're talking about data, we're talking about impacts on a system. The system we know is a collection of parts that work together. And we know that the Health Council itself is a system, and the Health Council works within a larger system of our community. And so we're talking about things at that level. Next. This data collection is really important to addressing health disparities. So we kind of need to refresh and remind on some of these complex concepts. The first being a health disparity. And what a health disparity is, it's a higher burden of illness experienced by one group relative to another. So for example, a health disparity that's well documented is that babies born to Black women are more likely to die in their first year of life than babies born to white women. Next. And that is, continuing with our example, we're looking at what we find is that differences in the health of Black and white mothers and their babies, even when it's adjusted for income and education, there continue to be differences. And so research and lived experience of Black women show that there are links between system responsivity and the care they experience causes a higher infant mortality rate of babies born to Black women. This is preventable and avoidable, and it's a health inequity. Next. So how does this all tie to REAL-D data? Well, let's start with understanding what it is and defining it. Next. So REAL-D is simply a set of standardized data and questions. REAL-D stands for race, ethnicity, language, and disability. We know, providers in our groups know that we have to collect it by order of the Oregon Health Authority. And you can see the House bill and the Oregon administrative rules noted there. Next. So REAL-D is important because we know that our historic and current systems cause avoidable health inequities, especially in lives of certain folks. And this harm is caused against people based on race, ethnicity, language, ability, gender identity, sexual orientation, and a myriad of other things. Next. Keep going. Keep going, one more. So how does collecting REAL-D data help address these inequities and disparities? It helps us identify and change the structural, social, and health barriers that are imposed on people that cause these inequities. It helps us better understand all the people we work with and serve. It guides how we create services to meet the cultural and accessibility needs of the people we serve. And it really helps us guide our funds and where we invest our funds to address health inequities. So that's one thing to understand if you're a service provider. Next slide. But the Health Council itself doesn't provide direct services. So why does this matter? Why does this is important to the Health Council? I'm going to open it up for a little bit of feedback.
Gwen, I think if we're not measuring our impact on different subgroups of the community, then it will be impossible to know if our goals as a health council and our actions around the health improvement plan are impacting and having the effect we want.
Great. Yeah. Other thoughts? Thank you, Linda.
Well, I would just add that it's such an important aspect of population health and an indicator of health outcomes across all populations. So to me, it's an important element in a portfolio of metrics to show our commitment to equity, social justice, and population health.
Thanks, Aman. Appreciate that. Yeah, you all have really hit on it. Next slide. And we see it in our purpose statement that you created. We exist to build an equitable ecosystem that improves the health of Central Oregon through collaboration and partnership, data-driven. So you can see all those components are already identified in who you've identified yourselves to be and want to be. And so Real D, and even Real D on ourselves as board members and staff and community partners partnering within the Health Council, next slide, because it is important because we want to understand who, we want to know more about who we're currently partnering with and who we're not. It's going to help us prioritize recruitment of future board members and other community partners. Understanding who we are is going to demonstrate support for the tool to improve health inequities within our region. And we're going to be responsive to partners and our communities who are asking, who is on your board and organization? Am I being represented? Do people understand my experience? And it's also going to help prepare us for supporting our partners with resources. As the Health Council starts supporting grant requests, many funders are asking, so who's on your board? Does your board represent your service area and region? So with that, next, we are inviting y'all to complete the Real D survey. Michaela will put the link in the chat. And this is purely voluntary. It's something our Community Advisory Council has already done and is a report requirement to the OHA. Staff will be doing it as well, and we'll be eventually asking our broader community partnerships to do that. These Real D questions and a few extras are in electronic format when you click on that link. The questions are designed, they may seem repetitive, but they're really designed after a lot of research and development to help elicit the most meaningful information from the participant, the person taking the survey. There are options in all the questions to decline to answer I don't know. So it's very voluntary, and any information you offer will be kept confidential. So I invite you to take, we're going to take maybe 6 to 7 minutes to complete it now. I invite you to click on your link and go ahead and run through it. All right, thanks everyone for completing it. If you're still needing a little bit of time, I do encourage you to fill it out. And we'll kind of wrap it up. So what's next for all this? So as I mentioned, the Community Advisory Council already shared theirs. We're reporting it out to OHA as we speak. You're sharing your information and staff will. We're going to continue to roll this out to work groups and committees and go through the standard process of cleaning up that data, analyzing it. We're going to follow best practices around aggregation and de-aggregation to make the information as meaningful as possible and valuable while maintaining privacy. And we're going to report results. That loop around closed loop conversation is super important. And then develop a response plan of where are our partners and where do we need to reach out more, and a lot of any other things that might turn up from that. So thank you very much, everyone, for sharing in the jazzy music and sharing who you are.
Okay, thank you. And any other questions or comments about that process? Okay, great. And so Ms. Berry, you have the floor.
Thank you, Rick. Hi, everyone. It's nice to see you all. I have the pleasure of being the staff person who was selected to share some updates around the Central Oregon Health Council's strategic plan. Kelsey really she's the yin to my yang in our development of things. And so I just want to say thank you, Kelsey, for that. The video that you all received 2 months ago when we were supposed to originally do this presentation was something that Kelsey fully created, and it just provided an overview of the strategic plan. I'm going to share my screen. Let me move you all out of the way here. There we go. Okay, so the video covered how the Central Oregon Health Council's 2020 to 2025 strategic plan was developed, how it is structured, and how it is being actively implemented and tracked. This plan was initially developed with many board members back in March of 2020, and it was reviewed and finalized by the current board of directors back in June of 2020. Since then, we've had a few new board members, and so we wanted to go over the design of the plan and the quarterly scorecard. And I was just thinking that perhaps the new board members actually don't have the entire strategic planning document. And so after this meeting, we'll make sure that gets resent out in its original format so they have access to that. So there are 6 strategic directions that surmount the obstacles and move us closer to our larger practical visions. And so these items in these boxes of color are the different strategic directions that will move us toward our practical visions. So within each strategic direction, there are multiple accomplishments that aim to be completed in a 2 to 3 year time period. These accomplishments help bridge our efforts and impact our strategic directions. The outermost ring right here are the continuously monitored action plans, which are updated on a quarterly basis. And currently there are actually 37 action plans at various states of progress. All of the staff members of the Health Council are involved in those in different capacities and are working with external partners as well as board members. So we strive to keep the board regularly updated at the accomplishments level right here. This level is also where we might seek guidance around any obstacles facing our action plans. So in your board packet, you're going to see these accomplishments on the quarterly board scorecard. These can be found on pages 67 to 73 of your board packet. So next to each accomplishment is a status marker indicating the current progress. Oops, sorry. So right here, you'll see these status markers. And if something has not started, you'll see a gray one that says it's not started and the quarter in which it will begin. So Q3 of 2021, for example, Q2 of 2021. It is noted on the implementation team the specific success we are working on toward which moves us closer to our strategic directions. So these are what success looks like if we achieve these accomplishments. And you'll also see this, the folks who are involved. So sometimes the board will be involved, sometimes it's the staff that are leading the charge in that particular action plan or accomplishment. Every quarter, you're going to see a different rotating quarterly spotlight. So this is at the end of your strategic plan report card, so page 73 in your packet. The spotlight highlights and provides greater detail on areas of the strategic plan where the board is directly involved. So this first spotlight, for example, we've given a few different items. And so in Q2 of 2021, including expectations in the COHC board policy book of board member organizations incorporating the COHC strategic plan and RIP priorities. And so below are the bullets that we're working toward regarding this action plan. So this will change every quarter, and these items will be specific to action plans or areas where the board has direct involvement. So obstacles will appear in the report card like the section outlined here in yellow. When an obstacle arises, the board will be informed at their monthly meeting, as we've been doing in this example. So this is a prime example of that. In some cases, we may seek greater board support if the obstacles are not being surmounted. Here we have an example of a success in the highlighted yellow section. So the current status is green, which means it's completed. And the previous status you can see behind it, which was light green, showing initial successes. And so we try to show that trend over time in this report card. So these completed accomplishments show measured progress within a strategic direction, which helps us move toward our larger practical visions. So in looking over that scorecard in your board packet, I'm going to stop sharing now, actually, so I can see your faces. Were there any facts that caught your attention that might be useful for us to kind of hear, so we can keep that in our minds and on our radar?
We're a real lively group today, huh?
I understand it's a lot of screen time.
Hey, Rebecca, I just appreciate the visibility. I think we just, with strategy being such a key governance role, so just the ability to kind of keep bringing this back. I love the quarterly update idea and kind of featuring one or two of the areas. One of the questions I just thought of as you were going through that, and I feel like I should know this, but I'm going to ask it anyway. In our 5-year strategic plan, what is our refresh cycle? Usually, a lot of times organizations will have a 3 or a 4 or a 5-year strategic plan, but with a rolling updated plan. So you're always looking 3 or 4 years into the future. Are we on an annual refresh cycle?
Yes. So every quarter we actually meet as a staff to update our action plans and make sure that we're tracking them. And if we're falling behind, making sure that we're paying special attention and bringing those items to the forefront. And we try to communicate that through the scorecard, but perhaps another way that we could do that is also to, on an annual basis, provide the board with an updated strategic plan. So that way they have the most recent updates. Would that be helpful?
Rebecca, I think where he's going is certainly at an operational level. You do a strategic plan at your best guess at what the future might be, and you get 2-3 years down the way and the future looks different.
I see.
Right. And, like many organizations a few months ago, I had to redo our strategic plan midway, just because of the COVID reopening and the issues we were facing. It wasn't giving me the right answers, right? Wasn't able to work on the right things. So I had to redo it. And so I think Dan's really speaking to that you go down the road a little bit and you sort of need to relook at that and modify, change, reality happens, that sort of stuff.
Thank you, Rick. I think that's a fabulous suggestion, and perhaps maybe one thing we can do to meet that recommendation would be to perhaps compile some sort of survey to ensure that we're still, the items that are mentioned in our strategic plan from a year ago are still currently the pressing items for this board. Would that be okay?
So I can jump in here and just give a higher level view of that. I think that for anybody that was actually at the strategic plan retreat in March of 2020, you'd agree with me that it was somewhat of a trauma invoking day. We will not ever have another retreat in March. I don't think I could actually do it. And that's a birthday I'd soon like to forget. Thank you, except for the chocolate covered strawberries. It actually in my light plan for next year, our retreat would be in May. But Dan, that would speak to directly what you're speaking to, is like looking at the strategic plan. Are we still who we thought we were? Are we still going in the same direction? What's changed? But also to actually tack some time onto it. So it's something that's continually living and growing. We can close out things that are done, of course, but there are things that we don't know what we don't know, right? And so I think that we will probably, I don't think September is going to hold enough time because we are going to be virtual. I'm not going to hold you for 8 hours. So I don't think that we will do that in September, Patty, to your text or your chat. But it will be probably early next year, I would say, but not March and probably not September, unless coming through the other side of the survey, we see that there's a lot of reason that we probably should plan to look at the strategic plan. So I think that that's also an open option.
Okay. Other questions about the strategic plan?
This is Linda. I think the quarterly reporting is great. I also, being a participant of a rep work group, find it to be of value as I think about the bigger picture. If there's one particular outstanding accomplishment or one challenge that a work group or a subgroup is facing, that would be a benefit for everyone on the council to know, just so that it informs us and we carry that with us every day. Somehow those linkages tend to be made that can be helpful to move through it. So maybe with the written report on the quarterly basis, maybe just a very brief, like our patient story, an example of a great accomplishment or a challenge one of the groups is facing.
That's a great suggestion, Linda. I suspect we can definitely do that. You're actually going to hear a report of the work group updates just after this, but something in written format is something we can also do. Any other recommendations or suggestions or questions?
Thanks so much, Rebecca. Rick, can I interject? I'm so sorry. Muriel needs to jump off in just a few minutes, so I thought I would take liberty.
Yeah. So as part of long-term strategic change, I was going to add, Muriel, you're abandoning us.
Yeah, I know. Sorry. Hey, I've been working many, many, many years, and I am excited to, sold my house, moving to Oro Valley, Arizona. And I'm looking forward to being near a big city and playing. And I did create a little business so I can keep doing some public health work on the side, but I'm actually really looking forward to it. It'll be fun. It's been a challenging year, to say the least. So, but I think, I was at those early meetings with Rick before COHC was even around. So it's, you know, it's good to know the pieces that I've offered to that and helped through the years. So thank you, everybody.
Well, and for those newer board members who may not know, Muriel has been both a statewide and national leader in public health for many years, and really just a remarkable resource for us and for little old Crook County to have someone of her stature working here, and was one of the originals in putting this stuff together. So really an important perspective, and we lose a great resource. She's been very remarkable, and that she also gave up the opportunity for her to say that she married the pool boy.
Now we moved to a place with pools, so he doesn't have to do that. Yeah.
So any other comments from anybody else? We have a lot of great comments coming in.
Yeah, I see you.
So sorry we couldn't have this live because we'd all give you big hugs.
I know.
We'd sob, we'd cry. So very cool. So thank you very much.
Thank you. And Crook County is doing a thing in the park for me on the 24th, along with Diane, who's my financial manager, who's also retiring, but she's going to stay on part-time and help Katie Plum and as they hire somebody else. But I just want to thank everybody for a lot of years of great progress towards health in Central Oregon.
It's 24th of June, isn't it?
Yep, 24th of June at Crooked River Park. We're outside. So,
okay.
Thanks, Rick.
So appreciate you. Okay, tri-annual report out, project managers.
And that's me to start. Hang tight. Let's project. All right, so we're gonna enjoy the barking of the dog as my teens get home. In the meantime, I'm gonna share I'm gonna share where the RIP work groups have been in 2020, just like y'all have been asking. So here we go. So a little quick reminder, the Regional Health Improvement Plan started in January of 2020. The region approved 6 priority areas, and each priority area has a variety of future state measures, which are just population level metrics. And these future state measures are our guide to our work. If you want more information and want to see all of these, you can pop on to our beautiful Central Oregon Health Data website. We continue to have really active participation in all of our work groups. Participation levels are holding steady since about fall of 2020. COVID definitely hit the work groups, but they're holding strong so far. We use multiple tools to convene our broad and diverse partners. This is a familiar tool called the structured problem solving, and it is just our skeleton process for building our regional shared understanding of our priorities and developing shared actions. For facilitating a broad community, we use a structured, participatory, consensus-focused community development methodology.
All right, so this slide shows how much each work group has spent to date, which is just under $1 million. We have met our 2020 investment extension, and we're on track to meeting our 2021 spending deadline. And each work group is committed to spending $500,000 yearly over the life of the RIP. Next slide, please. At the beginning of April, the Operations Council established the RIP Advisory Group, and this group's role is to advise with the implementation of the RIP, act as a liaison between their own organizations and the RIP work groups, support as project managers with addressing barriers as they arrive, And then also help project managers create alignment and coordination between the QIM and the RIP measures as they overlap. Next slide. So a few of the barriers that we're facing that the RIP advisory group is helping us address. The first one is consistent participation. This is important because our work builds on itself, and it also takes time to reteach and reorient members. We know continued COVID demands and fatigue play a role in this, and it also affects our availability of expertise working in each focus future state measure. We also work with a lot of sectors that have been hard hit by COVID, including public health, healthcare, social services, and schools. Folks are also expressing that they're suffering through Zoom fatigue. And like most summers, we anticipate many folks will take time away, and this will inevitably slow down our progress.
All right, so I'm going to go over a few examples of emerging work from the implementation strategies for each work group. Next slide. Okay, so Address Poverty and Enhance Self-Sufficiency has just funded 5 projects to increase high school graduation rates among students who are economically disadvantaged across Central Oregon. And they're in the process of developing a multi-phase project to address the needs of those who are asset limited, income constrained, and employed. And this project will conduct listening sessions to determine unique needs of different communities. Listening sessions will have a special emphasis on housing and transportation. And results will inform diverse approaches for each community to improve outcomes and meet the future state measures. Next slide. The Behavioral Health Work Group is investing in behavioral health professionals in rural areas, completing baseline research to identify a timeliness and engagement measure, conduct feasibility study and develop recommendations, and implementing a pilot program to test and champion coordinated use of screening tool and method to measure appropriate levels of follow-up. Next slide. And the Promote Enhanced Physical Health Across Communities work group is developing a request for letters of interest to address increasing youth fruit and vegetable consumption and physical activity. And they're also developing a strategy to expand Connect Oregon in order to increase partnerships between clinics and community-based organizations. And this strategy is in partnership with the Poverty Work Group and will focus on food insecurity and youth fruit and vegetable consumption. Next slide. The Stable Housing and Supports Work Group recently invested $200,000 over a 3-year project in the development of a regional housing council to address the housing crisis and homelessness. And they're currently reviewing a proposal for permanent supportive housing to address chronic homelessness and reduce the frequent use of emergency resources in Central Oregon. Next slide. And the Substance and Alcohol Misuse Work Group is enhancing ESPERT within clinics to address binge drinking, assessing key drivers of binge drinking for 18 to 34-year-olds, and reducing youth vaping by working with retailers on product placement, price, promotion, and prevalence of tobacco products, alcohol, and food. So for example, the project may provide signage, refrigeration, and revitalization to promote healthy foods with requirements to decrease advertising for tobacco, sugary foods, and alcohol. And this project will utilize best practice policies for preventing the sale of tobacco and alcohol to minors. It will leverage project activities to provide community education around harms of youth exposure to tobacco advertising. Next slide. And finally, Upstream Prevention is investing in activities that support letter name recognition and reading. They're continuing the successful Ask Anything media campaign supporting planned pregnancy, and they're developing and funding a regional immunization facilitator shared across organizations. Next slide. And I think we have plenty of time for questions.
So everyone feels like they know what they want to know about what all these RIP work groups are doing. Because if you complain to me, you won't get any sympathy because this is your time to speak up. So
I have
Out
a
of
question.
curiosity, this Gary Allen, one of the obstacles was consistent participation, and related to that, have you identified any gaps in the people that should be participating in these RIP work groups because some expertise they would bring or communities that they would represent, and what efforts are made, if there are gaps, to recruit those people to the work groups?
You want me to take it? Okay. We've had good participation from some people, and the folks who haven't been there have been taken away by COVID efforts. And as we're moving forward into specific strategies, we recognize that certain people aren't there, but I think the recruitment of individuals is really happening at that level now. So looking at the specific strategies that they want to work on and then recruiting based on those needs. Anything else, Gwen or Michaela?
Divya.
I had the same question. My question really was kind of beyond the, I guess the second part is beyond having enough people engaged in this work. Do you have concerns with any, do you have any other kind of concrete concerns around being successful in achieving the goals of these RIP groups, in any of them?
Well, I can tell you in the two work groups that I'm in, it's like, well, there's some big goals there. It's like, and they're going after them, and the process is fine, but getting more mental health providers to work in Jefferson County, well, we can't get them anywhere. So, there's, like in any plan, there's things beyond your control. But I don't want to speak for the staff who have a broader picture of what's happening in all the work groups, but there's certainly, this is challenging times to do much of anything. So I don't know what the staff think as they look across the whole thing.
Yeah, I'll add, it's been interesting watching the groups evolve because their measures are all really different. And some of the measures are really system level, like a lot of the behavioral health ones are like, how do we change our system? Which they're pushing on, and they have been for the last few years. And so we're seeing kind of evolution of change and culture and practice. And we know that just works a lot below the surface before we start seeing it pop up and make it like a visible change that the patient would experience. And then there's other measures that are super broad. And so their approach is taking more, let's fund the work being done, and it can look a lot of different ways, but meet these requirements. And so I think we're going to be moving, the goal is to always move towards the metrics. And I think I see the work groups doing that, and that's very much a shared intent and value. And they're using a lot of different approaches, some getting at root causes, some just saying, okay, we're going to put money here and do this. And that being said, kind of going back to the expert question, we're pulling on folks as we're able to. And I think there's a recognition throughout of how do we change or find different ways for engagement for folks that might not be able to sit in the meeting, but we really still need their involvement. And that's, an evolutionary process I think we're trying to take over the next 18 months to 2 years, just structurally for the Health Council. Justin, yeah.
So just a suggestion, because I think Divya's question was really good. I've been to, I think 2 or 3 years worth of these meetings. I'd love you just to like maybe make one meeting where you just said like, hey, Justin, your organization could do this, and that would really help. I've never had a progress report one time in 3 years where, and maybe that means you don't need anything from my group, and that's fine, but if you need help leveraging these big systems changes, every leader and is supposed to be here for that. Tell me. I'd love to know. You can call me if it's not during this meeting, like whatever, but if you need help leveraging big changes and my group isn't available or there, I'd love to know that. Because honestly, I think they're participating in everything and you're getting what you need, but if you're not, that nothing can help move change like this forum. And I'm fine with the transparency you saying it's my group that you need help from. Because everyone else on the group will go, okay, Justin, maybe it's time for you guys to kick it into high gear. So I don't like the whole, it's all done in a separate room and it doesn't come here. So bring it here. I'd love to hear it. Even if it's my group that needs the help. Just a
Thank you.
suggestion.
Yeah, no, thanks. We welcome that. That's something, we're navigating and trying to, find that alignment and role between all these lines of business that we've got. So thank you so much. Appreciate that.
And Megan, were you going to say something? Hard to monitor everything.
No, but thank you for noticing something.
You got alive there for a moment, so okay. Anybody else? Good, thank you. Good questions. Anything else for the board meeting? Okay, then I would suggest a motion to adjourn.
Well, with honoring the amazing work of the team, like really great report outs today, really good materials, a lot of work goes into all of this. So just know that that is appreciated and acknowledged. And with that, I'll recommend we adjourn the meeting.
Second.
Okay, all in favor? Aye, aye, we're done. Thank you very much.